Hello, everyone. Good afternoon, New Mexico. Welcome to the first of four scheduled end-of-life options New Mexico webinars on medical aid in dying. Today's topic is how to respond to a request for medical aid in dying. I want to thank you all for joining us today. But first, the housekeeping. Just note that this session is being recorded for future training use. Your questions are welcome. Please type them into the Q&A box at the bottom of your screen, and we will address as many of these as possible after the general presentation during the discussion period. So, I am Robert Drake, Bob Drake, past hospice and palliative care chaplain, now medical outreach manager for Compassionate Choices. I'll be moderating today's discussion. I'd first like to introduce our speakers. First, it is my honor to present Dr. David Grube, National Medical Director for Compassionate Choices. David practiced family medicine in Philomath, Oregon for 35 years. He responded to his first request for medical aid in dying in 1999. Since 2015, he has been the National Medical Director here at Compassionate Choices. David is one of the most experienced teachers of the processes of medical aid in dying in the United States. He has mentored scores of providers, and he operates our doc-to-doc telephone line, helping to introduce prescribing providers across the U.S. to medical aid in dying and lecturing worldwide on this topic. Presenting with Dr. David Grube is Barak Wolff, MPH. He is a mostly retired, longtime public health leader in New Mexico, having worked in rural primary care, EMS, and trauma systems, and as the Director of Public Health Division in the New Mexico Department of Health for more than 25 years. Barak has served as a senior analyst for the New Mexico Senate Health and Public Affairs Committee for the last 17 years, and when they are in session. For the last 9 years, Barak has been deeply involved with end-of-life issues and is on the founding board of directors for the newly created nonprofit End-of-Life Options New Mexico. He expressed gratitude for this opportunity to help improve our care systems and support New Mexicans in their end-of-life decisions, now including medical aid in dying. Very briefly, what we'll be covering today, the learning objectives are to integrate medical aid in dying into end-of-life care, to identify the issues of professionalism and personal integrity in end-of-life care, and to understand the requirements of the New Mexico Elizabeth Whitefield End-of-Life Options Act. And with that, I'd like to turn this over to Dr. David Grube. David.
Thank you very much, Bob. It is also my honor and pleasure to be here with you today. And I hope that this is a fruitful conversation that we have, and that we can provide a lot of information on your new bill and new act. As Bob mentioned, I am a retired family physician, and this sentence from Atul Gawande's wonderful book, Being Mortal, strikes me as a very, very important sentence. Life is meaningful because it's a story, and yes, in stories, endings matter. Next slide, please. Now, I'm a little embarrassed about this slide. It's a bit out of date. It only goes up to 2015, but it reminds us that death of our patients is not really the enemy. The enemy is intolerable terminal suffering, because indeed, even with the fascinating technology that we have in modern medicine, nevertheless, we will all die. Next slide, please. And it's getting very complicated to die. In modern medicine, as Atul Gawande outlined in his book, the process of aging and dying is no longer a natural experience. It's become a medical experience. And he outlines in the book how we have become alarmingly unprepared for these prolonged and extended deaths and in the intolerable terminal suffering that may occur during them. COVID has made this all worse. Now, these are end-of-life options that each of our patients has the autonomy to choose if they have capacity. And we're going to not focus on the others of these, although we will talk a lot about the wonderful value of hospice and palliative care today. But essentially, our topic today is medical aid in dying. Next slide, please. Yes, medical aid in dying is the practice. It's a medical practice in which a terminally ill person, someone with 6 months or less to live, who has capacity, that means understand informed consent, requests from their clinician, and I have this as a doctor's prescription, but in New Mexico, as Mr. Wolff will outline for you in a minute, that is not always going to be the case. But an individual chooses to self-ingest to stop their intolerable terminal suffering. It's important not only for you to learn about aid in dying because of your clients in the state of New Mexico, but with modern medicine and people traveling all over the place, it's important to realize that 1 in 5 adults, or 20% of Americans, now have this option in 10 states and the District of Columbia. And quite a number of other states are looking at legislation, as New Mexico recently did, to pass the ability for citizens of those states to receive aid in dying. These are the requirements. Again, I want to repeat this because I think it's really important. The individual must be an adult and a resident of New Mexico. They must have a terminal illness. They must be able to understand informed consent and be volitional. And self-ingestion is a requirement. We'll speak about that at length, not only in this webinar, but in future webinars that I hope you can attend. Next slide, please. There are so many myths about aid in dying, and I hope today that a lot of these will be removed from your thinking if that some of these you were wondering about. Aid in dying is not a failure of palliative care or hospice. In fact, when it's integrated into these medical programs, it is just one option. It is not always easy to access, and Mr. Wolff is going to address that a bit also. It is also not true that hospices are opposed to aid in dying. And in Oregon, where I live, and in other states where aid in dying has been passed, as well as New Mexico, hospices are understanding that they can integrate this into their policies. Very important is the language, and we're going to talk more about that. Medical aid in dying is not suicide, as several organizations, including the American Academy of Family Physicians, have clearly stated. And it is not possible in all cases to, we're not able in medicine to assuage terminal suffering in all cases. That's not true. Next slide, please. So their request. This topic today is how to respond to a request. Well, the entire medical team, not just the clinicians of the advanced care nurses or the physician assistants or doctors, but the nurses, everyone needs to be prepared. So you need to understand, and that's, of course, why we're having this webinar today. We need to clarify the reason, and that takes investigation and listening, and to understand the context, and then to document these requests and the reasons for the requests in the chart, and understand the motivation. Rather than just respond that we don't understand aid in dying, I'm sorry that we can't help the person, we need to ask them, why are they requesting this option? Very important. One of the tenets of medical ethics is not to abandon our patient. We have to have a commitment to support their choice, whether or not we agree that this is something that we would participate or not. And very importantly, we need to explore all options. And when we have these conversations, we do explore the options: hospice, palliative care, alternatives to in end-of-life options. And if this is not something that we understand or can participate in, we must refer. That is the professional thing to do. We don't refer for aid in dying, we refer for a discussion of end-of-life options. Next slide, please. So the most important thing then is to use our ear, which is hopefully connected to our brain, so that we can listen to the request, to try to understand the request, the context, the motivation, and not to just stop and say, well, this is not something that I understand or do, but to listen and have these end-of-life conversations. In Oregon and other states where aid in dying laws have been passed, These end-of-life conversations have improved immensely. It's palliative to have the conversation. Next slide. Now, the request may be direct. The individual may be quite specific, and in fact, most of these patients you'll find will be quite specific, and in fact may have talked about this when their cancer diagnosis was made 5 years ago. But it could be nuanced. And so that maybe something like this question, isn't there something, doctor, that you can help me with? They very likely, because it's a new law in New Mexico, may be uninformed. And this is also a cultural thing. Some portions of our society do not have education or understanding about what their options are. I'm often asked, should the doctor bring up the topic? And if that's a situation that may be necessary or possible, we can use the palliative care palette of discussing with the individual who's about to die how they envision their last day. And we can ask them those questions like, who would you like to be with you at your death? Where do you want to be? What is the situation? Do you want music? Do you want, but you can also say then, would you like to determine the day? And that simple question can open up their mind to possibilities. Next slide, please. Yes, understanding the motivation. It's interesting that to be quite often, people think that the reason that individuals request aid in dying is because they of pain, but actually we're doing a better job, aren't we, in medicine of controlling end-of-life pain. It's the suffering that is the problem. Intolerable terminal suffering, which could be such things as no pleasure, could be such things as existential suffering. But we need to remind ourselves again and again that it's not about us wondering what their suffering is. It's their description and their suffering, and we don't define their suffering for them. Yes, these people are sad. They're all about to die. But that's different than depression. They may have depression, but certainly probably all of them have a grief reaction because they would like to continue to live. It's just not going to be possible. Next slide, please. As I mentioned earlier, it's so important to commit to supporting our patient's choice. These are very intimate conversations. The patients are vulnerable. That's why the language is so important, and our attitude is so important. The contemplation of this option can increase their sense of loneliness, and we need to be aware and sensitive to that. But having the conversation, as I mentioned, is palliative. I can't tell you how many times when I had these conversations with my patients, the size of relief that they had when I just said to them, I'll listen, I'll honor your choices, I'll be with you, I'll walk with you. And of course, they can change their mind. In fact, many do, and that's fine. It's about them, not me. Changing their mind is okay. And as you'll learn in these webinars, fully a third of people who go through the whole process and get the prescription, fully a third, don't end up taking the medication. Next slide, thank you. So it's part of your law, but it's just good medicine to talk about other options, including palliative care options, hospice options. In most states that have aid in dying laws, almost every patient, 19 out of 20 in Oregon, are enrolled in hospice. We need to discuss this with the family. It's very important, and there are rare occasions where it's not possible or the patient does not want that. But this is something that we should be discussed with the family, and including their spiritual counselors, their chaplains or rabbis, etc. And again, addressing the specific concerns and advanced care planning conversations are important as well. So as I mentioned, hospice and medical aid in dying can go hand in hand, and indeed in many non-Catholic hospices in Oregon and other states, that is indeed the case. In my own hospice here in Oregon, we have integrated aid in dying into all of our policies. It's really important to understand that this is patient-centered. The level of participation from hospice to hospice can vary to just non-integration, but also it could be integrated without support. Whereas a hospice may say, okay, we'll allow a patient to do this, but that's it. To hospices such as the one where that I'm involved in here in Oregon, where we allow our medical director to be the consulting physician or the attending physician. The nurse can be present at the time of ingestion, et cetera, et cetera. So good to know what your local hospice's policies are and help them develop those policies if possible. Next slide, please. Again, there's a tension here sometimes between our personal beliefs and our professional integrity. The most important thing to remember as a professional is to put the patient first. They are the one who is about to die. We need to support them. It's not about what we personally believe. So language matters. Referral is important. As I mentioned, if you do not refer for a request for aid in dying, you refer to discuss end-of-life options. I'm reminded early on in my practice when I had a young woman with appendicitis that I referred to a surgeon for an appendectomy, and it turned out she had, of course, an ectopic pregnancy. It wasn't appendicitis, but I had set the family up for an appendectomy, and the surgeon was the one who had to help me and the family in counseling about what the real diagnosis was. So the referral is for discussion of end-of-life options. Next slide, please. Now, this is one of my most important slides, and I think about this so often. If people are opposed to aid in dying, they often use the term physician-assisted suicide. And I wonder about that because we all understand what medical aid in dying is, and it's kind language. It's not hurtful language. And why should we as clinicians use language that is hurtful or makes the dying person or their family more sad? So please use non-judgmental, non-shaming language and act as a professional in a kind way. Next slide, please. I'm going to actually sort of come back to this if we can, because I want to leave time for Mr. Wolff to give his presentation. This slide just mentions that my first patient asked for aid in dying back in 1999, and I didn't know exactly how to respond. And so I sought the counsel of the medical director of our local hospice, who mentored me. And subsequently, that's one of the reasons why I continue to mentor others. So having a prescription for medical aid in dying medication is palliative in and of itself. People use the law because of loss of dignity, anhedonia, loss of autonomy, no pleasure, and to end intolerable terminal suffering. Those are the reasons repeatedly. And pain control is generally not on the top 5 of the list. It's very important to note, and we have experience now in Oregon almost a quarter of a century, and other states as well, Washington over 10 years, etc., that sub-minority groups such as people of color, the poor, people with disabilities, they are not being coerced or abused. This is an individual choice, and it is an option for them as an individual, and there's not evidence of any coercion, etc. All of these people who request aid in dying are, by definition, about to die. And so the same number of people have died in those states where aid in dying laws have been passed, but suffering has been diminished. And I think that's the take home, isn't it? So there are a number of potential barriers, and we can get to these in this webinar and in other webinars. They fall in the categories as I've listed them here, as the patient themselves and some of the problems that the individual person might have, understanding their resources, their support, cultural questions, religious questions, etc. I'm more saddened, I guess, by the barriers that we provide as clinicians by not supporting our patients' choices, by acting unprofessionally, by not listening to them, And sometimes, though, we do have restrictive covenants in our healthcare systems that do not allow us to participate. And Mr. Wolff now, in just a minute, is going to describe some of the ways that New Mexico's law has addressed that. And then, of course, institutions themselves have some, and I have many anecdotes about that. So be familiar with your statute. Make sure you document as you would document any other healthcare thing that you're going to do. Consider using navigators, particularly licensed clinical social workers in the hospice setting, are very helpful for the family and the dying person. Telemedicine is allowed for any component, although documentation is extremely important. And this does take time and patience, but that is something that we do have, and it is not something that the dying person has. Next slide. I'm going to turn this over to Mr. Wolff now, and then I'll be back for questions and answers. Thank you very much for your attention.
Thank you so much, Dr. Grube. I appreciate that. And, you know, I wanted to just take a minute right at the front end. And on behalf of End of Life Options New Mexico, and really all New Mexicans, I really want to express our thanks to Compassion and Choices. Over these many years, they've been incredibly generous and hardworking as national partners, helping us to move forward first with our advocacy and then with our court case starting in 2012 and all the way up through the current activity of trying to implement our new law. We would not be where we are today if it weren't for the active role that Compassion and Choices has played as a national partner. In fact, this last weekend, the CEO of Compassion and Choices, Kim Callanan, did an op-ed in USA Today, the national newspaper, that really just calls out New Mexico for passing such a progressive and helpful law to increase access to medical aid in dying. And it goes through and shows how other states are now moving forward to try and revise their laws to implement some of what we have already at least put on the books. We're going to post that op-ed up on our website, so do take a look at it. Really, it just filled me with pride, and I was most appreciative. I also do want to mention that the other major national partner, Death with Dignity National Center, has been generous with their support and their technical assistance to us. Again, you don't do this by yourself. We need the experience nationally to keep moving this forward. So to move forward a little bit with Elizabeth Whitefield, you know, as most of you know, it took us here in New Mexico 3 legislative sessions over 5 years to get this passed. It was a heavy lift, but a good process. You know, I think ultimately our success was a combination of dedicated and energetic statewide grassroots advocacy, effective leadership, and amazing legislative champions in Debbie Armstrong and Senator Liz Stefanik. They were outstanding in their understanding and their compassion and their capacity to know what was going to work and how to maneuver through the system. You need to have that. But of course, let me also take a minute and just talk about our friend Elizabeth Whitefield, beloved judge who was a member of our End of Life Options Coalition as we did our advocacy. In 2017, she testified with her trach and her oxygen and sort of pulled herself up to say what she wanted to say. And she looked those legislators right in the eye, many of whom she knew from her work as a family court judge all these years. And she just told them why this was so important. In 2018, she continued to work with us. And that summer, she had a very tough death. And we all grieved and knew that we wanted to name our effort in her honor. So Elizabeth Whitefield was one of a kind, and she's part of the spirit that we bring to the work that we're doing here in New Mexico. Next slide, thanks. So I'm going to be pretty brief in this overview. Many of you know about our New Mexico law, I'm going to highlight kind of where it's similar, but mostly where it varies, and why Kim was able to write that op-ed piece, and why we can feel proud about the potential we have to expand access to medical aid in dying. The details of our bill are well documented on our website, End of Life Options New Mexico, as well as on the Compassion and Choices website, where they've devoted a number of pages to helpful pieces, not only for families and patients, but also for clinicians. So do take a look at the websites for the details. But basically, in terms of qualified individuals, it's the four that Dr. Grube already mentioned. You have to have a terminal illness with a 6 months or less prognosis. You have to have the capacity to make healthcare decisions. It has to be a voluntary request, no undue stress. And you need to be able to self-administer the meds, although, there's some openness about that. So we're just like every other state in this regard. We would have liked to have been more progressive here, but, passing legislation is a fine art. And if you try and be too progressive or get everything you'd like, you run the risk of not passing the bill at all. And whereas we would have liked to have expanded that capacity and that terminal illness, rather, to be different than just a 6 month prognosis, we ultimately decided that that's what we would go for. Next slide, please. This is an area where we did cut some new ground. And this was not a heavy lift. We had to, be clear on what we wanted, to add advanced practice nurses and physician assistants to our physician cadre, our allopathic and osteopathic physicians. But we have a terrific legacy and history here in New Mexico, with very strong practice acts and good experience in using mid-level providers, not only in the rural areas, but also in urban areas to complement many areas of medical practice. We felt that it was really important to expand this capacity of consulting and prescribing clinicians out to our mid-level providers. However, once again, in order to get this passed, we had to compromise a little bit and indicate that in every case, at least one physician would conduct an appropriate examination and make sure and certify that the individual was qualified. So under our rules and under our act, we could not have a PA and a nurse practitioner, one be the prescriber and one be the consultant. You would need to have one physician involved in that decision point. And that was a good trade-off, and we were pleased to make it. In terms of capacity, we had a strong basis of making those standards because of our New Mexico Uniform Healthcare Decisions Act, which was passed way back in the mid-90s. We were one of the first states in the country to have that kind of uniform act, and it has served us well ever since. That presumes that people have capacity to make healthcare decisions, and only to the contrary does that have to be proven. And similarly, our law builds upon that. Our clinicians need to certify, and if they have any concern about the requesting individual's capacity to make an informed decision, they are required by our law to make a referral for a consulting opinion and assessment, and then having the results of that back in the medical record, either that the individual does have capacity, or if they don't have capacity, then they won't be eligible for medical aid in dying. I think that's good practice. It's what is going on in the other states. We defined our mental health professional definition very broadly, again, to enhance access. We include psychiatrists, psychologists, social workers, psychiatric nurse practitioners, et cetera. Again, wherever possible, we wanted to give people as much access to this as we could. In the prescribing area, again, fairly standard. Prior to prescribing, the provider must inform the individual about all end-of-life options, and we specify palliative care and hospice. we want to make sure that one is not better than the other. These are complementary treatments, and patients need to know their full range of possibilities and options. And we believe strongly in that. Everything must be documented and in the medical record of the prescribing clinician. The affirmation of terminal illness by a consulting provider must be included, or in our law, we allow that consulting, that affirmation of terminal illness to be accomplished by their enrollment or acceptance and enrollment in a hospice organization. And that has this, what we call our hospice exception, I think affords us a much more streamlined approach. As Dr. Grube said, the preponderance of people who use medical aid in dying are hospice patients. We also have a form, and the form is specifically called out as the request to end my life in a peaceful manner. And that form is in our law, and it's worth a read. It's very explicit. It makes it clear that the requesting patient understands their diagnosis, understands their prognosis, understands that this medication will indeed kill them, and they need to initial in a number of places and sign it at the end, and it must be confirmed by witnesses. That is all specified in the law. The other place where I think we have done well with our laws in reducing the waiting time, streamlining the process. The prescription, once written, does have a 48-hour waiting period before that prescription can be filled at a pharmacy. And that is the only waiting period we have in our law. And if a clinician decides that the patient may not survive that waiting period, that 48 hours, they can waive it. We have a number of other states now that are moving in that direction to reduce the waiting periods. I think in California, the experience is about a third of the people who request start the process don't conclude it. They die before they can obtain their medications. And we didn't want that to happen here in New Mexico. As in all states, the prescribing provider will be responsible for reporting information to the Department of Health. We have a form that's out there and a public health order that provides some guidance about where and how to send that form at the completion of the medical aid in dying death. And then we have a whole host of other provisions that are very important and central. This right to know is really quite expansive. This gets beyond medical aid in dying and those who are going to prescribe it. This really is setting up a clinical expectation for medical practice in New Mexico that terminal patients will be afforded a discussion with their providers about the range of options that are available to them. Everything from palliative care to hospice to starting or stopping treatment, that type of thing, as well as medical aid in dying. And that is pervasive, not just with those who are prescribing. And then again, as Dr. Grube spoke about the importance of the language in the law that is absolutely explicit, that medical aid in dying is not suicide. That helps us with issues around insurance, where there's a concern that suicide life insurance policies will not, pay off if it's a suicide, or in other instances where suicide becomes a negative for the patient and the family. Suicide is a critically important issue and a major public health challenge. This afternoon at 3 o'clock, University of New Mexico is putting on an ethics seminar where Peggy Batten, who's a known national figure, is going to be discussing, is there a rational approach for suicide? And if you are interested in that, exploring that topic with Peggy Batten, you can go to our website and download the Access, Zoom invite at 3 o'clock this afternoon. We have in our law, we have liability protection for not only for the providers, but we have protections as well for the families involved with the dying patient. In other words, all of this is voluntary. And we wanted to be sure that everybody who's going to be involved in medical aid and dying had the kinds of protections that would keep them safe and secure, that they are doing a legal and appropriate thing for their loved one, and not having untoward consequences following that. We can go into more detail in that, but I think you got to know that we have a comprehensive law that has these protective provisions. And that brings us back to what we're hoping to achieve with our end-of-life options New Mexico. You know, for all these years, many of us have been strong advocates and have been focused on advocacy. But our commitment to the cause was such that there was no question that once we got the bill passed, that we were going to assist in its implementation. And to do that, we stand on the shoulders of organizations in Oregon, Washington, Vermont, California, that have taken on this work from a nonprofit perspective to provide services, to do outreach for both clinicians and for the public, so that people understand their rights to self-determination, and they also understand their options and certainly understand about our medical aid and dying law here in New Mexico. This brochure is brand new. We just put it up on our website if you want to download a copy, or on our website you can also make a request and get some hard copies. We're going to be distributing them widely across the state. Excuse that incoming call. And I can't get rid of it. I'll talk over it. So again, we're pleased to have that, and do download a version. Next slide, please. And I think this is my last slide. I thought I'd wind up with a little bit about just sort of what are we experiencing so far since June 18th, if you will, and how's medical aid and dying going here in New Mexico? Well, again, we're incorporated. We're awaiting our 501c3 nonprofit designation, so we can continue to work with donors to sustain our operation. We've got subcommittees that are building the basis, the foundation of the programs of outreach, education, and individual support, where we will be using a volunteer network that we basically screen and train and then support. You need to know that there have been a number of ingestions in various communities throughout the state, from Las Cruces up through Santa Fe and everywhere in between. From what we understand, they've all gone well, and that the families feel like they're being well served, and there's a lot of gratitude about the peaceful deaths that are resulting. There are several hospice agencies that have fully incorporated medical aid and dying into their scope of services. And in some cases, that includes prescribing by their medical director or their clinicians. In other cases, it's providing supportive services before and after ingestions, and in some cases during ingestions. And they have an important role to play, hospice, following the ingestions, in managing with the medical investigator and making sure that the body is well tended to. Hospice, we just can't say enough about, given our law, how important their participation is going to be, and we'll continue to work with them across the state. And finally, you know, some of our largest healthcare systems, Presbyterian Healthcare Services, which has 7 hospitals, I believe, across the state, is supportive. And they've developed a streamlined system for approval of those who are eligible, as well as the data collection. They've got this all online for their clinicians. They're still working on getting a cadre of clinicians, getting them trained and on board with taking on the prescribing role, but we're confident that that will come. UNM, basically this Health Sciences Center, our tertiary hub in New Mexico, has taken a little time to get themselves organized, to do their homework, to develop their policies and their forms, and to get some of their clinicians trained. We understand that they have a number of clinicians, and we expect that they will start their services statewide or receiving their patients from statewide in October. So we feel good about what's going on to date. Please stay tuned. We're about to have a new website launched in the next 3 weeks that is going to incorporate, move away from the advocacy and more into the service that we expect to provide over these coming years. So with that, let me send this back to the good doctor, and he's going to sort of take us home, and then we'll open it up to some questions and answers and see if we can meet your needs. Dr. Grube.
Thank you very much, Mr. Wolff. Very insightful, and it's interesting having worked in this arena now for a quarter of a century to see New Mexico's law and how it addresses a lot of the barriers that we still have in Oregon and other states. So in summary, I'd just like to take maybe 90 seconds here and say a few things. Medical aid in dying is not, if individuals choose this, it's not because hospice or palliative care programs failed. And we can integrate this option into palliative care and hospice programs. And it's palliative, having conversation, end-of-life conversations, so important to recognize that. It empowers those who are dying to have their wishes heard and honored. It's very important to remind ourselves it's not about us, it's about the dying person. That's maybe the most important thing to remember. And it's hard to do that sometimes when the choice that they're making may not be the choice that we would wish for them. I just can't say enough how important it is for us to be kind in our language and in our attitude and in our actions for these people who only have a few more days with us. And patient autonomy and professional integrity are our standards of care. And our personal beliefs are something that we have an honor inside our heart, but they're not what was taught to us in medical school. Next slide. So, and finally then, the enemy isn't that the patient will die. The enemy is intolerable terminal suffering as defined by the dying person. So as I've taught medical students for 30, 40 years, only two things matter: comforting the dying and respecting their wishes. Thank you.
Thank you, Dr. Grube. Thank you, Mr. Wolff. Beautiful presentation. We do have some questions that are coming in. The first one is kind of just around the CME, the continuing education, whether or not this information will be available. Yes, we will get certificates out to you. We have your email through your registration. Please note, though, if you are a physician, as that will be a little bit different certificate. So, Dr. Grube, how does a physician determine which medication to prescribe?
Yes, that's a very, very good question. And we're going to have a webinar coming up on that specifically. I'll address it briefly here in case the person who asked the question won't be able to attend. Essentially, historically, it was easier than it is today. We used rapid-acting barbiturates, either pentobarbital or secobarbital, which were, just could be prescribed. But now those are no longer available in the US at all. And so a regimen, which has a long kind of name, called DDMA-PH is what's prescribed. It's a compounded, and it's a regimen of 5 medications that is ingested by the dying person. It's comes in about 4 ounces of water or juice, so a half a glass. Time to loss of consciousness is about 10 minutes. And then there's a gentle sleeping and a peaceful death in about 1 hour. So we'll talk about that specifically in a future webinar. But you can contact me in the Dr. Doc line if you'd like more specific information.
Thank you, Dr. Grube. This to either of you, what is meant by the term resident in the New Mexico law?
Mr. Wolff, I'll let you have that, Mr. Wolff, because
okay, certainly. That does vary state by state. Some are quite explicit and some not so much. We chose with great intention to not be explicit in our law, and therefore it just talks about a resident. And when you research that, if you do, you'll find that there's probably 20 different, either by regulation or in some cases by legislation, definitions of residency for New Mexico. It varies whether you're applying for a resident scholarship or you're applying for a loan or this or that. We think that evidence of residency would certainly be a driver's license. It would be a bill with your name on it. It would be an address, you know, a local address. But we are really leaving that determination up to the clinician. In most cases, if you have somebody in hospice or someone who's been seeing a clinician, they're going to know that patient and they're going to have the address of the patient. We don't think this is a showstopper. We did not think that people would be flocking into New Mexico from out of state. There's been no experience in the other states. I think Dr. Grube can speak to that. And I think if someone did want to come here, they would come here for aid in dying. They would come with enough time to clearly establish a sense of residency. So we were intentionally vague. And if anyone's going to raise the question, that would be the clinician.
Yes, thank you, Mr. Wolff. I totally agree. And I think it's really important to remind ourselves the population that we're speaking about. The population that we're speaking about are people who are about to die. And you have in your law 6 months, but most of these people have a week or two when they've given up all options and choices. So they're not able to fly from New York to New Mexico for this option. It's not something that you will see, and we've not seen it in Oregon, and it's not been seen in other states either.
Thank you both. Dr. Grube, a note of clarification request. When you say 90% of the patients are in hospice, does that mean that 90% receive prescriptions for hospice, or just that they are enrolled in hospice?
Yes, the data that we have in Oregon is that I think last year was 92%. It goes up and down in the vicinity of the low 90s of individuals who ingest medication for aid in dying are enrolled in hospice. So people who do the ingestion are enrolled in hospice.
Have you seen a relationship, Dr. Grube, around the country to the introduction of these laws and the number of patients that become enrolled in hospice or interest in hospice or palliative care?
Oh, absolutely. There are a number of papers that have shown now that in states that have aid in dying laws, hospice utilization improves and increases. And also, interestingly, the inappropriate use of hospice does not increase. And this is measured by discharges. So without a doubt. And so, for example, in Oregon, we are now in the highest quartile for both of those statistics year after year in the United States.
Thank you. With respect to long-term care residents, people in long-term care, how might the place where they're living, their policies affect the patient's ability to access this law?
It varies. I think some long-term care facilities have policies that allow this, and most of them don't have any policies. So that'll be something that Mr. Wolff and EOLO in New Mexico will be working on, so that long-term facilities can have policies. It's also quite interesting that in my experience, so many times for the ingestion, the person is discharged from the facility to their old home, where they could be with their loved one, their pet, their music for the ingestion. So that's also seen.
Thank you. This is a related question, and I think you alluded to this a little bit earlier. Are hospices required to participate in medical aid in dying?
Yeah, let me be, let's bring that to New Mexico. Again, I would just want to reiterate how strong our conscience clause is in our law. Absolutely nobody is required to participate. For healthcare entities, and that would be hospitals, hospices, long-term care, assisted living, you name it, for institutions, if you will, if they are not going to provide this service as a matter of policy, the law asks them or requires them to make that clear on any of their public information, whether it be a website or a brochure, or we recommend as part of their intake procedures. The challenge becomes where somebody thinks that they may want aid in dying down the road, and they don't ask that question, and they get into a facility that they choose, and ultimately the facility, hasn't been as clear as they could be, and then they have to make decisions of either not having the care that they wish or transferring out, perhaps to another hospice that will provide the service. So we're going to try and front end that and work with institutions so that their policies are clear and are posted. You know, we want everybody to do a good job with their end-of-life care. I've been working very closely with the Christus Hospital here in Santa Fe. I just took them 300 brochures, yesterday, and have been talking with the Vice President of Missions and the Vice President of Compliance. They have opted out. We know of several other hospices that have opted out, and they've clearly stated that. And that works to everybody's benefit. By no means does that imply that they aren't going to provide excellent end-of-life care and make good referrals that refer to those who will provide the service, or even the way our law reads, they can also refer to our organization, which is why it's good for them to have our brochure, because part of our role will be to help facilitate referrals in a confidential way to those providers who are willing to participate in medical aid in dying.
Thank you. It sounds like you're busy.
Oh, yes. A lot to do.
Another question, if the death certificate does not indicate anything about medical aid in dying, how do the states keep track of, generally, or how does New Mexico keep track of the rates of utilization of this new law?
Yeah. Again, and Dr. Grube can kick in, the states vary about whether or not they address the death certificate. Our bill initially did address that and said that the cause of death will be the underlying disease. And that, in a matter of cleaning up the act in the Senate Judiciary Committee, they made several amendments that were accepted to streamline the bill. So right now we're silent on that, but we've been working very closely with the Office of the Medical Investigator and with the Vital Records Department of the Department of Health, who basically work with the death certificates. And we're essentially providing information to the providers that the death certificate should be the underlying disease, the underlying cause of death. It is not a medical aid in dying or suicide or anything else. It is the underlying cause. So where we get the information is in the reporting back to the Department of Health. Again, that is posted on our website. They put out on July 1st a public health order and a form that's to be used. It's very simple in conformance with our law. It's not as extensive as some of the other states like Oregon or Washington, where they collect a lot of data. We're collecting a minimum data set, but we will be able to get a sense of how the utilization of medical aid in dying grows over time or not, and who's using it, that type of thing.
Great.
Yeah, there are two purposes, really. There are two purposes for the death certificate. One is to establish the estate. It's a legal purpose. And the other is the medical purpose, which is epidemiology. So the epidemiology is understood as Mr. Wolff outlined. And furthermore, these are public documents. And this is it's kind of a HIPAA thing, really. The person is about to die of lung cancer. If they self-ingested, that's not public information.
Thank you. Dr. Grube, what is your experience in other states about the top diagnoses that people die of who utilize medical aid in dying?
Well, by far and away, it's cancer in all states. Other diseases seem to be sort of a little bit on the rise, but still they're small. ALS is a tragic disease that's always fatal and degenerative neurological conditions. There's a number of these, including Parkinson's. Some other diagnoses include severe congestive heart failure and lung failure. But by far and away, it's cancer.
Thank you. What role do hospice staff play in supporting the families before and after ingesting the medications? And what if you have a chaplain who personally disagrees based on his or her religion?
Well, certainly they have that right to disagree and opt out, as Mr. Wolff said. And so the hospice itself should have a policy that that individual does not need to participate. But the entire staff of the hospice, every single member needs to understand what aid in dying is, and all play a very important role, clear down to the bath aid and respite care volunteers. So yes, there are always opportunities to opt out, but it's so important for each member of the team, whether it's the licensed clinical social worker, the pharmacist of the hospice, the particularly the nurse. I always offered to attend a planned death in my patients. And interestingly, more often than not, who the dying person wanted to be with them at the time of their ingestion beyond their loved ones was the hospice nurse.
Thank you. Thank you very much. I think we've got time for one or two more questions here before we close and talk about resources that are available. Dr. Grube, could you share a little bit about how telehealth or telemedicine works with this law?
Well, sure. And of course, we've all learned a lot about telemedicine in the last 18 months, haven't we? And realized that the value of it. Well, these are a couple of important things to remind ourselves. These are very, very sick people. And for them to come in another time to the office is difficult for them and for their family. These people are well known to our system. They've been in cancer treatment for the last 5 years. They've had their diagnoses and their questions answered and asked and conversations. So it's not, almost all of them, this is not something that comes up out of the blue. So telemedicine works pretty well. You know, you can look someone in the eye, you can have a good conversation with them, you can document that. These are people that are known to us. So all the components of telemedicine can be, you know, any of the components Mr. Wolff outlined in New Mexico can be used in telemedicine. And we've really found it's helpful for the family and the dying person not to have to get back into the office one more time.
Thank you, Dr. Grube. Matt, I wonder if you could progress to the next resources slide. But very briefly, is for telehealth, telemedicine, is video required? Is the camera required, or can the telephone itself work?
The telephone itself can work. It's better to have a video, certainly, in my opinion. It's not always possible, but it's almost always possible.
Thank you very much. Thank you both. Let's take a look at the resources that are available. Know that we're also always available to take questions. End of Life Options New Mexico and Compassion and Choices will be here for you. So you see the website here for End of Life Options New Mexico and a telephone number to this newly formed nonprofit. Take advantage of them. Compassion and Choices, we have websites for your state in particular and resources that are available there. The doc-to-doc line that we mentioned in the very beginning that Dr. David Grube persons and has for a long time is available. Death with Dignity, of course, National Center. The American Clinicians Academy on Medical Aid in Dying is a newly formed organization that offers some really wonderful trainings, as well as new information on the pharmacology of this as it changes a little bit. And also available is a CME for physicians through Medscape that is available for you. So I think, yeah, our upcoming trainings, there are 3 more. So we invite you to be present. Hope you enjoyed this one today. The next one is the role of hospice in medical aid in dying. pharmacology, and then call your attention to the City of Hope End of Life Symposium in mid-December. That will be both virtually and in person. It's an incredible offering. I suggest you take a look at that. So with that, we thank you all. Dr. Grube, Mr. Wolff, thank you so much. Matt behind the scenes, and blessings on all of you from wherever blessings come from in your world. And thank you so much. Stay healthy.